Deadlift is one of the most challenging exercises, so it really shouldn't be a surprise when our patients and clients struggle to learn the movement. But here's the thing, how many of you can relate to the scenario of providing mobility exercises and corrective exercises but still come up short with the proper deadlift technique? Well, what I want you to do is to take a step back and understand that the structure of your patient or client is what dictates their deadlift success. This means that the rib cage and the pelvis are going to influence your patient or client to be better at moving more horizontally, such as a deadlift, or more vertically, such as a squat. And in this video, I want to break down the structure and the biases that the human body has so you can understand why your patient or client isn't the best deadlifter, but also how we can improve their deadlift technique. So the first step is understanding the structure. Now, if you want to dive deeper into this, I would encourage you to check out the PT Growth Academy's Performance Redefined course. This is an online self-paced course where you have 8 modules to dive into the why and the how in much more detail compared to this video. But for this video's purpose, we're going to keep it simple. We're going to talk about general principles so that you can take this video and put it into action in your clinic and or gym. So the general theme that you're going to see with someone that struggles to deadlift is that they're going to be in more of a flexion-based posture. So we're going to see an increase in that thoracic kyphosis, a little bit more of a rounded over, bent over posture. At the ribs, the response from this is going to be a depressed rib cage and an angle of the ISA that is less than 90 degrees. As it relates to the pelvis, it's going to be biased towards a posterior pelvic tilt. This posterior pelvic tilt is going to further drive the ability to move in a vertical trajectory instead of the desired horizontal that we see with the deadlift. So that's the general posture and pattern that is going to make it difficult to move in the deadlift fashion. But let's go ahead and zoom in on the pelvis because the pelvis is going to play a big time role in your patient or client's ability to move horizontally. Now, like we already said, the pelvis is going to be in a posterior pelvic tilt. Well, what happens here and what does it really mean and do for you? Well, a posterior pelvic tilt is going to be when the sacrum moves posteriorly. This posterior direction is going to compress and push and open up the pelvis. And this is really the secret. This is where the problem lies. If we think about it, and remember that there's muscles back here. We have our posterior pelvis muscles back here, such as our external rotators and our glutes. And what they're going to do, because of the position and the leverage that the muscles create on the pelvis, it's going to compress. Now, if you think about this as like a door, if a door is closed and you push back into it, are you going to get through the door, or is the door going to win and stop you? The door will stop you, right? And that's the same exact thing with the human body. There's a door back here. So if we have too much compression, too much stiffness back here, we don't have the ability to push in that horizontal trajectory that we need with a good deadlift. So what happens as a result? Well, this person, because they like vertical movement, although they may be deadlifting, they're going to squat the deadlift. So we're going to see a lot more knee flexion, and they're going to move more vertical instead of more horizontal. So instead of just throwing out random mobility and corrective exercises, take the principles that we just talked about, the overcompression here, and all we need to do is get them good at what they're bad at. These types of people are really good at vertical trajectories, i.e. squatting, but they struggle because they don't have enough expansion or space to move horizontally. So what am I indirectly saying? I'm saying that you need to provide them strategies that allows them to expand back here, to go into more of a nutation, i.e. an anterior pelvic tilt, which is going to create expansion posteriorly and give them compression anteriorly. When you provide this strategy for your patient or client, you've unlocked their ability to actually push back. You've unlocked the door so they can now walk through it. Just like we see with a deadlift, if the door is closed, i.e. the muscles are compressed, when they try to push back and go in a horizontal fashion, they're going to be met with a locked door. So they go back, and because that's all they have, they then stay here but flex through the femur. So when you unlock the door, when you give them eccentric length and provide them in an expansion bias back here, you've now opened the door so they used to get stuck here, but now they can continue to expand in that desired horizontal motion you're looking for. So a good starting place is a PRI exercise that is called right side lying adductor pullback. And the basis of this is it's going to create eccentric length at that posterior pelvis. So when your patient is in their side lying position, they are working on moving the left back and the right forward. Now, a lot of people do this and they feel the muscles that they want to feel, but they don't really understand the why and what that does. Well, if we flip the pelvis around, if we're moving back on the left side, remember this posterior pelvis is compressed. So when we try to do it, it doesn't want to happen. But when you do this right, you actually start to open up this pelvic outlet. That is going to unlock your patient's ability to hinge in that horizontal direction. Now, as your patient or client is going through this exercise, you're going to want to put them on their right side, their feet on the wall, so they get that sensory awareness. That sensory awareness is then brought in to cue your patient into finding their inner heel. The inner heel is going to promote IR strategies. IR strategies meaning the hamstrings, the inner thigh, and the glutes. And from there, we're going to work on a pelvic tuck. Next, we're going to work on drawing that left back, pulling the ball back on that left side without losing and dumping into our pelvis, but maintaining a good overall position. Once you do this, this is when you're going to start to work on getting that eccentric length of that posterior pelvis, but then also reinforcing with the appropriate muscles on the anterior side of the leg. Exercise number 2 would be a left hip capsule release. And this is a fairly straightforward exercise, but it's doing the same thing, but in a different position. So the intent here is to open up that posterior pelvis and start to drive eccentric and length throughout those muscles. So all you're doing here is putting your patient in a quadruped position, but what you want is to put them in a position where the left knee can be back compared to the right. You can do this with a towel, you can do this with a foam pad, anything that you have will be sufficient to draw back. From here, what we're cueing them is 4 good breaths to start to open up and move the rib cage while expanding the left posterior pelvis. The third exercise is a split stance deadlift. Now this is getting closer to our traditional bilateral deadlift, but here the intent is exactly the same that we've seen with the other 3 exercises. We are just increasing the level of difficulty. So here you want to use a slant board. The slant board in a toes elevated position is going to unlock internal rotation and pronation, strategies that you need to appropriately hinge in a split stance position. So have your patient or client in a toes elevated position with the side you are working back. As your patient goes down, you are cueing them to rotate through the pelvis, just like we saw with the last 2 exercises. And as they go back, they should feel that slight burn and that stretch sensation in that left posterior glute.